Hey Murat, what are you doing?
Pericardiocentesis.
Why?
Fluid around the heart.
For ECMO to flow, you have to have adequate flow in the venous system, especially the RV or the IVC or SVC where it's draining from. If you don't have it because it's compressing it, then you will not, it will basically collapse it and you will not flow.
So this is classic for any hypovolemia, anyone who has increased intrathoracic pressures or increased intrapericardial pressures. You're going to have the same thing, yes. You have a patient who has tamponade and needs instant relief by evacuating the fluid from the pericardial space. The traditional way of doing a pericardiocentesis, most of the time it's subxiphoid. Problem is that you have a lot of intervening structures. You have the liver, and then it's very difficult to actually access the space here. So what's really better is to try to find a point where you really actually have a big anechoic rim or a big target for that pericardial fluid. I really believe that most of the time you can get a good view from the peristernal view. The peristernal approach, which means placing your linear transducer probe peristernally right next to the sternum, and then you look in between the interspace with ultrasound, you can actually see the pericardial fluid and then the heart beating below that. Now when you put your linear transducer probe right here on the chest, the way it'll look like, it'll have two ribs that cast shadows. In between, you'll have the intervening interspace, and you actually find that pericardial fluid underneath, and you'll see the heart beneath. I found that it's much easier to find a good rim anteriorly right next to the sternum. That's where you'll always find fluid, and the added advantage is that if you do access that space from this angle, the catheter will always wrap around the heart. Because you're inserting from medial to lateral, the wire will go medial to lateral, and when you place your drain, it'll actually wrap around all the way across posteriorly, and you'll find that you have maximal efficient drainage.
A quick question though, are you concerned at all about vessels?
You are, yes, and that's why you always have to pre-screen for your right there. Okay, and that's your lima. So you want to put it in the long axis. So you will use your linear transducer probe not only to find where the pericardial fluid is, but where that vascular structure is with color Doppler. And you're going to mark it, and you're going to avoid it, and you're going to make sure you never go near that with your needle. So always be careful of the lima. It's right here.
What you doing?
Floating up the needle.
What's that?
What?
This.
Needle.
Okay, what's this?
A French catheter.
Okay, what's that long thing here?
That's the drain.
Okay.
Then I will put it in the long axis. I find the long axis is the safest way to do this. Placing it in the long axis within the inner space, you will then pass the needle through across the chest from medial to lateral. You will watch that needle go through and pierce into the pericardial space. It's just on top of the pericardial fat.
Yeah.
So it's perfectly placed. Okay, can I get agitated saline?
What are you doing, John?
Agitating the saline.
And Murad, you're injecting to make sure that the catheter is pericardial, right?
Correct.
That's the only thing we try to agitate, nobody else.
So there's agitating.
Once I've accessed the space or where I think the space is, I will then inject agitated saline and confirm that it's extracardiac, confirm that it is within the pericardium before I dilate. And so you need to confirm that you are actually in the pericardial space. The catheter will wrap around, it'll drain everything, and stays in stable. You will then dilate, you will then put your drain in. It's very important never to dilate in the ventricle. Serious. If you have good control of ultrasound, good control of your needle, you can dynamically watch it go through, accessing it from a point where you have a larger anechoic rim, a larger target with that pericardial fluid is better. In the peristernal approach, if you have a good rim of fluid, you can use dynamic ultrasound guidance to access that fluid. And it becomes as simple as a thoracentesis, as simple as a paracentesis, and it becomes a safe, life-saving procedure.